Hi, I'm Dr. Frankie Holmes. I recently had a patient who wasn't doing so well, and we had to have a difficult conversation. We had been together for a very long time, and she'd had a number of clinical research medications, but they had stopped working. This led to thoughts about what is compassion at this stage of a person's diagnosis. So I thought a lot about this, and I would like to share my thoughts on compassion. I recently read an amazing fact in this really fun book, Before Happiness, by Shawn Achor. He is a Harvard psychology researcher who does happiness research. And that fact is, every second, not minute, but second, our brains receive 11 million bits of information. These can be outside stimuli like my dog barking, the phone ringing, or internal stimuli like, gee, where did I put my keys? I'm in a hurry. Or, gee, there's some kind of beep, worrisome text message on my phone. Or, gee, is that my kid on the phone? However, and this is the key point, our brains can only process 40 bits of information per second. That means that we have to selectively filter out lots of stimuli to focus on a particular issue. Now think about that. When we communicate with another person, their brain is also trying to figure out which 40 stimuli to process and which of the 10,960 stimuli to ignore. It boggles my mind to realize that we can be effective communicators at all, because we really do have to be on the same page with most of those 40 bits of information. So therefore, it's not really surprising that many times we're not on the same page, even though we're in the same room talking about the same topic. And this is especially true for communication about health issues, and even more so when these are issues of life and death. I decided to become a medical oncologist when I was an intern. I had a patient named Willie who was brought by his buddies to the ER, where I was assigned on that rotation, because he had been falling out. Patients who did not have a doctor or insurance were cared for in the intern and residence clinic under the oversight of senior hospital physicians. Because Willie didn't have insurance or his regular doctor, he became my patient. We found Willie needed a pacemaker because he had heart block, probably caused by his smoking and poorly controlled blood pressure. Once he got the pacemaker, he went back to work, and I followed him in the clinic. However, he developed a cough, and we discovered he had lung cancer. In the late 1970s, we did not have lots of very effective treatments for small cell lung cancer, but I worked with our oncology senior doctors and tried our best. However, the tumors grew, and one day he came into the ER. Since I had moved on to another rotation, one of my colleagues was in the ER and he called me. "Your patient is here, Frankie. He's pretty sick and he's asking for you. I don't think he's going to make it. You better come quickly." I immediately squared away my hospital patients and came down to see him. He was very weak, but he took my hand and asked me to do a big favor for him. "Of course, if I can, Willie," I said. "I want you to tell my common-law wife how much I love her. I have always had to hide her, and she always felt that I didn't really appreciate her. Please do this for me." "Willie, of course I will, but I want you to tell her yourself. We'll call her now." "I can't do it, Doc. Please tell her." Willie passed. We could not find his wife, or she was afraid to come forward. But that moment never left me. I realized that taking care of cancer patients meant that I would be there at the most vulnerable moments of their life. Just as I would want someone to be as kind and caring with my mother if she were dying and I couldn't be there, I wanted to be that kind of doctor for my patients with cancer. But not just for their final moments. I wanted to be with them to help them through their journey. So much of life for an oncologist is looking at the glass as half full, not half empty. And also remembering that there are so many reasons to celebrate. One of my favorite sayings is, "Life is short, eat dessert first." I have to say parenthetically that this had disastrous consequences for my husband, but we have since addressed that. Due to the incredible advances in the understanding of cancer and the explosion of technology, many of our cancer patients are living long lives even with incurable cancer. Some patients do not die because of their cancer, even though it's not cured, but they die of heart problems or stroke or diabetes. That means that I often have long journeys with them. And some of these journeys are getting even longer due to research. I was trained in clinical research at UTMB Anderson Cancer Center under the mentoring of Dr. Aman Boustar and Dr. Gabriel Hortobagi. Both are internationally recognized experts in breast cancer. However, I fell in love with research when I had the opportunity to do a clinical research trial with a new drug made from the bark of the yew tree in 1990. The drug had been discovered in the mid-1960s on a search of plants on land and ocean, but was stored away until 1977 when Susan Band Horowitz, a PhD, did research showing how it worked by blocking cancer cells from being able to divide. In 1986, the National Cancer Institute requested Dr. Hortobagi to investigate this new drug in breast cancer patients in a clinical trial. Dr. Hortobagi asked me to be the principal investigator on this project. I wrote a protocol. This is a scientifically rigorous evaluation of the merits of a new treatment, the known and possible side effects, and our plan to assure the safety of patients who would be eligible, and how we would analyze the results to determine if it were really effective to kill the cancer. But, and there are always buts in clinical research, just as in life, the medicine came from the bark of the yew tree, which grew in mountainous areas that were difficult to get to. Also, many of these yew trees were in areas that were protected habitats due to the endangered white-spotted owl. So it wasn't until 1990 that enough of this drug was available, and we at UTMB Anderson and my colleague, Dr. Andrew Seidman at Memorial Sloan Kettering, were each approved to treat 25 patients. The very first patient I treated with Taxol was Linda. She was a single mom with a young son about 9 years old. She worked in a pawn shop, and she could not sit down on her job or she would be fired. However, she developed severe back pain in her low back. Eventually, she saw her doctor, who referred her to UTMB Anderson because she had a history of breast cancer in the past. I saw her, ordered the x-rays and the scans that indeed showed a large tumor in the low back where the spine meets the sacrum. We biopsied it, and the biopsy did confirm that it was breast cancer that had spread to the bone. The tumor had eaten away the bone, and that clearly explained her severe pain. Linda, there is a new medicine that has just been approved for testing by the National Cancer Institute that looks very promising for your tumor. We are doing a clinical trial, and I think there is a good chance that it could help you. Are you interested in being treated on a clinical trial? I asked her. Anything to help this pain. I have to work, and I can't sit down, she said. After we reviewed all the pros and cons of the treatment with her, and she signed an informed consent, she was the very first patient treated at UTMB Anderson in the Breast Medical Oncology Clinic with the drug we now know as Taxol, or by its generic name, paclitaxel. In those days, we gave one treatment with a very high dose every 3 weeks. It caused a lot of bone and muscle pain during the first 2 to 3 days, and we had to give cortisone-type medicines to prevent allergic reactions. By the 5th or 6th day, most patients were feeling better. So how are you feeling, Linda? I asked when she came in for a checkup after the first treatment. How's that back pain? I was hoping to hear that her pain was improved. That back pain's okay, but my muscles were killing me that first week. What can you do about that? No kidding! Suddenly that horrible pain that was keeping her from being able to work without sitting down, it was gone. It was just the side effects of the medicine that we had to work on. I realized that this drug is a powerful treatment for breast cancer, the first one since the 1970s when adriamycin, doxorubicin is the generic, or the red devil, had been discovered and found to be so effective. In the trials at UTMB Anderson and Memorial Sloan Kettering Cancer Center, more than half of the patients treated with Taxol had shrinkage or complete disappearance of their tumors. I was summoned to the National Cancer Institute to bring all the x-rays and scans of our 25 patients and present them to the director. Because there had been no new drugs this powerful in the past 10 years, the NCI wanted to see the x-rays and scans with their very own eyes. This was too important an opportunity to get incorrect or confusing information. So there I was, the youngest faculty member of the breast medical oncology team at MD Anderson, presenting the research that would reflect on our entire cancer institute. If I weren't so tired, I would have been more scared. For the month before the presentation, I had been going into the clinic every morning at 5 in the morning and systematically lining up all the x-rays, marking where and how large the tumors were at the beginning, and then how they shrank after every 2 treatments with Taxol. The requirement in those days was that the tumor had to shrink by at least 50% to qualify for what we call a partial response, or PR, and it had to completely shrink away for a complete response, or CR. We had 3 patients whose tumors completely shrank away and 11 patients whose tumors partially shrank. The panel of senior cancer doctors and researchers were quiet. "This is real," one of them finally said as I finished my presentation. At that moment, I knew I could never treat cancer patients unless I could keep doing clinical research. I wanted to be able to help discover medicines that offered patients more than was available in the present, but instead medicines of the future. In the 26 years since I first treated Linda, our understanding of cancer, and breast cancer in particular, has exploded. We've discovered that cancer is not just a queen-size pantyhose type of disease. It's more like a Russian doll. You know those big dolls shaped like an egg that you can take the top half off, and then you find another smaller doll inside, and then an even smaller doll each time you keep taking the top off? This is important because it means that we can divide and conquer. Some types of breast cancer are killed or slowed down by anti-hormones or by immune treatments. Some types require multiple chemotherapy drugs. But we can now target treatments like a smart bomb instead of just bombing all the targets, even those that may not be helping the tumor grow. For every patient I treat, I try to find the very best treatment, whether that is a drug like Taxol that's now an approved drug, or whether it is a new research drug that, like Taxol at one time in the beginning, has a lot of promise. Some patients can live a long time with these smart treatments, but some don't. And that is where my first experience with Willie comes in. In those days, there were very few investigational medicines like Linda had, and getting access to them meant going to one of the big cancer centers like the National Cancer Institute or MD Anderson. At that time, a diagnosis of lung cancer was a death sentence, and everyone understood that. Famous personalities of the day, Edward R. Murrow, the newscaster, whom you may remember from the movie, and Arthur Godfrey, who was a famous radio personality, among others, had died of lung cancer from smoking. So Willie knew that the lung cancer would eventually take his life. But we had a long relationship of trust. He trusted me to do my very best to help him with his lung cancer, just as I had with his heart problem. When the medicine stopped working on his lung cancer, and he knew he was dying, we were on the same page, sharing his last moments together. We talked honestly as he prepared himself to meet his maker. Nowadays, however, the situation is different. The media often report miracles from research, and sometimes that leads to unrealistic expectations. But unfortunately, as Steve Jobs' death showed, even with the most advanced research treatments in which cost was no limitation, there remain cancers that cannot be cured and that eventually kill patients. And that is where compassion comes in and the difficulty begins. In the classic movie with those powerful actors Morgan Freeman and Jack Nicholson, both playing men diagnosed with different but deadly diseases, a new word came into the vocabulary of dying, the bucket list. When Jack Nicholson realized his time was short, he made a list of the important things he wanted to do before I kicked the bucket. Knowing his time was short empowered him to take charge of his life and try to tie up those loose ends, especially his relationship with his estranged daughter. Despite the expected endings, there were moments of joy as Morgan Freeman deeply reconnected with his wife, and Jack Nicholson was allowed to meet his cute-as-a-button new granddaughter, who had been absent from his life. Those patients had already heard the bad news and processed and accepted it. They relied on their doctors to keep them updated on how things were going so they could continue to work on their bucket list. However, some patients can't hear the news. They cannot accept that death is coming. Dr. Elizabeth Kubler-Ross wrote about this in her eye-opening book in 1969 on Death and Dying, What the Dying Have to Teach Doctors, Nurse, Clergy, and Their Own Families. Patients need to process this truly life-threatening information. Some patients get stuck with the shock and denial or anger. Of the 11 million bits of information flooding their brains, that brain that is literally scared to death, the 40 bits they filter out are negative, and that causes anger. Often that anger is turned against the one who gave them the bad news, the doctor. Shoot the messenger. Even if doctors try to give bad news in a gentle way, relying on the same relationship like the one Willie and I had over many years, the fear of death and anger that the doctor can't prevent it, or perhaps even causing it by saying it out loud, is perceived as being uncompassionate. Dr. Eduardo Bruera is a nationally recognized expert in supportive care, including death and dying, at UT MD Anderson Cancer Center. He and his team studied 100 patients who were asked to watch 2 videos in which there were 2 actors, one playing a doctor and one playing a patient with a worsening cancer. They had a conversation about how the patient's tumor was doing. In one situation, the tumor was getting worse. In the other, the tumor wasn't doing as badly. In each situation, the doctor gave an equal number of caring statements and had equally empathetic facial expressions and gestures. Now remember, this was an actor playing a doctor, so they were quite able to follow the instructions of the psychologist. One doctor had to give bad news, and one doctor had to give news that wasn't as bad. By almost 2 to 1, the patients felt that the doctor giving the bad news was not as compassionate or trustworthy. So, unless doctors can give good news, some patients will always see them as lacking compassion. Of course, there are always gentle ways to give bad news, and the doctors in the videos had been instructed in the best methods and used them. But still, 61%, 3 out of 5 of the patients, felt they were not compassionate. Sometimes the doctor cannot reach the patients through this shock, anger, or denial. The truth will set you free, the Bible tells us. Cancer doctors believe that cancer patients should accurately know how their disease is doing. Not as in the past, when some patients never even knew they had cancer. "Don't tell mother, it will kill her." It was a common situation when I first started seeing patients as a doctor in training at MD Anderson Cancer Center. Rather, now we want patients to understand that when cancer is no longer shrinking and when the treatments are given and cause side effects, not help, and the patients are getting weaker, that time is limited and time is very precious. This may be the only time left to repair or enrich those special relationships, to think about what you want your children or friends to know or remember about you, to come full circle and know what was your own life's meaning and purpose. And while none of us wants to think about this, there is a gentleness in having this time to come to terms that doesn't happen when a person suddenly dies or is killed and has no time for those special last moments. In the end, we will all die. My husband, who's the joker in our family, says, "Cemeteries are the place to be. People are dying to get in there." We can't change that fact, although we hope that living healthy will delay that as long as possible. However, we can change how we let the knowledge of death affect our family, our relationships, and us. Oncologists try to do their very best to give treatments to prolong life of good quality, and when the treatments are not helping, we'll compassionately share that truth with you in hopes that you can use that precious time with those you love. This is how I practice compassion with my patients who are dying. Thank you.